Bismillahirrahmanirrahim. Today we are going to discuss the blistering or bullous diseases of the skin. Following are the references for this disease. These are the learning objectives for this lecture. At the end of this lecture, the fourth year MBBS student should be able to describe the structure of the basement membrane of the skin, enumerate various types of bullous skin disorder, differentiate between inflammatory and non-inflammatory bullous diseases, and describe their morphology and pathogenesis. So we have got a clinical problem in which a 51-year-old man present to your clinic complaining of painful blisters over his entire body. He notes that he currently has several ulcers in his mouth as well, and on physical examination you note that there are severe bully and the blister appear when you rub his skin with your finger. When we attempt to classify skin disease, we can classify these diseases on the basis of the site of origin or the anatomic structure that is involved. One group is disease of the epidermis, and that include ichthyosis, diarrheal disease, psoriasis, and pemphigus vulgaris. Another group is disease of basement membrane zone, that is the dermal epidermal interface, and this include epidermolysis bullosa, bullous pemphigoid, dermatitis herpetiformis, erythema multiforme, systemic lupus erythematosus, and lichen planus. The inflammatory diseases of superficial and deep vascular bed include urticaria and angioedema, cutaneous necrotizing vasculitis, allergic contact dermatitis, granulomatous dermatitis, sarcoidosis, and granuloma annulare, while scleroderma is the disorder of the dermal connective tissue. The paniculous inflammatory disorders are erythema nodosum and endoretum, while acne vulgaris is also an inflammatory disorder. Then there are infections such as impetigo, superficial fungal infection, deep fungal infections, viral infection, and arthropod infestation, and variety of benign and malignant tumors. Some skin diseases are also affected or also manifestation of the paraneoplastic syndromes. Then there is another way to classify these diseases, and this is done on the basis of the process, the pathologic process or morphological appearance of the lesion. One is the epidermal maturation disorders, and it includes ichthyosis. Then acute inflammatory dermatosis include urticaria, acute eczematous dermatitis, and erythema multiforme, while chronic inflammatory dermatosis include psoriasis, seborrheic dermatitis, and lichen planus. The bullous or blistering diseases of the skin can be divided into two groups: inflammatory blistering disorder that include pemphigus, bullous pemphigoid, and dermatitis herpetiformis, and non-inflammatory blistering disorders that include epidermolysis bullosa and porphyria. The disorders of the epidermal appendages are acne vulgaris and rosacea. Paniculitis is the group that includes erythema nodosum and endoretum, and other types of paniculitis are also there. Then disorder of pigmentation and melanocyte, freckle, lentigo, melanocytic nevus, dysplastic nevi, and melanoma, and benign and malignant tumor along with adnexal tumors of the epidermis and dermis. Now a brief review of the layers of the skin. Outermost layer is the stratum corneum that continuously desquamates. Below this layer is the stratum lucidum that is thick and this is pinkish in color. Just below this there is stratum granulosum, and this stratum granulosum has got a granule-like appearance, and it contains purplish cytoplasmic granules, and below this prominent layer of stratum granulosum there is presence of stratum spinosum. Stratum spinosum has got polyhedral cells that have got prominent intracellular bridges, and all these layers rest on a prominent basal layer. And over here, this basal layer is showing a brownish pigment that is melanin, deeply brownish pigment that is melanin. And this circle is pointing towards the papilla, uh, upper, that is upper papillary dermis, and here blood vessel is present, and this blood vessel has got its role in the regulation of the temperature. The basement membrane is the interface between the dermis and epidermis. It has got diverse function, and it has got a complex nature. It is responsible for the dermal epidermal adherence, and it is a selective macromolecular filter, and also it is a site for complement and immunoglobulin deposition in certain diseases. And most structure of this basement membrane zone are secreted or produced by the epidermal cells, and the basal lamina is the primary organizational feature of the basement membrane zone, and it is responsible for the epithelial cell polarity and some keratin gene expression. The structures that are included in this basement membrane zone are deep aspect of basal keratinocyte. There is a plasma membrane. Over here you can see that there is the plasma membrane, and this plasma membrane along with tonofilament, and these attaches to the deep face of the hemidesmosome. Okay, then hemidesmosome along with its subdesmosomal dense plate that is marked by this red plate in this picture. Just beneath this blackish desmosome, then anchoring filaments. These anchoring filaments extend from the subdesmosomal dense plate across the lamina lucida, and they insert into this greenish lamina densa. Then lamina lucida is composed of adherence protein, while lamina densa is composed of type 4 collagen, dense type 4 collagen. Anchoring fibrils are down there, and these anchoring fibrils are composed of type 7 collagen, and they bind this lamina densa to the papillary dermis. And microfibrils are there also. These are thin reddish microfibrils that are delicate long elastic fibrils. So from outer to inner side, the basement membrane parts are deep aspect of basal keratinocyte, hemidesmosome, anchoring filament, lamina lucida, lamina densa, anchoring fibrils, and microfibrils. So now recall the structures we just discussed. Recall in your mind the structures from above to the down to the dermis. Then this electromicrograph is showing the lamina lucida, lamina densa, and there is a desmosomal attachment plaque that is marked by this arrow, and down there into the papillodermis the anchoring fibrils are also visible. As this basement membrane is a complex structure and it has got a unique morphology, it has got some antigenic sites that are important in the development of the skin disorders, especially the blistering disease of the skin. One antigenic site is for laminin. Laminin is present in lamina lucida and lamina densa, and it binds type 4 collagen. It is a glycoprotein, and it is present in both these layers, the lamina lucida and lamina densa, and it is responsible for binding of type 4 collagen. There is another antigenic site that is bullous pemphigoid antigen 1 and 2 that is concentrated in the hemidesmosomes and basal keratinocyte. It is important in bullous pemphigoids. Then there are type 4 collagen. This type 4 collagen is concentrated in the lamina densa. This lamina densa is the most superficial component of the complex network of the collagen of the dermis. And it is also important in the dermal epidermal attachment. The type 7 collagen is present on the deep aspect of the basal lamina in the anchoring fibrils, while the anchoring filament 1 and anchoring filament or anchoring fibril 1 and anchoring fibril 2 antigenic sites are present in the anchoring fibrils and lower part of the lamina densa. The pathology of the bullous diseases of the skin is associated with the keratinocyte adhesion molecules. There are desmoglein 1 and desmoglein 3, two important proteins, and one of this desmoglein 1 is more concentrated in the upper layer than the lower layers, while desmoglein 3 is more concentrated in the lower layer up to the stratum spinosum, and it is almost absent in the upper layers. So the antibodies against the desmoglein 1 will result in subcorneal blisters, as happens in pemphigus foliaceus, and the antibodies against both the desmoglein 1 and desmoglein 3 will result in suprabasal blisters, as happens in pemphigus vulgaris. This picture is showing the composition of these desmosomes. This desmoglein that is present in the uh, that is the site of the problem in pemphigus is attached to the intracellular structural protein through plakophilin and desmopalakin, and it is attached with this tonofilament and giving the support to these cells. It is There is another protein also that is responsible for the support, that is desmocolin. While the hemidesmosomes, uh, they have got some specific structural protein. One is the BPEG1, that is bullous pemphigoid antigen 1, and this bullous pemphigoid antigen 1 connects the intermediate fibers with the laminin or and subsequently the anchoring fibril through the Bullous pemphigoid antigen 2, that is the pemphigoid that is responsible for the pemphigoid. When there are antibodies against these bullous pemphigoid antigen 2, there is formation of the blisters that are at the level of the lamina lucida of the basement membrane. While when there are antibodies against the anchoring filaments, these anchoring filaments, and these antibodies will result in the disease dermatitis herpetiformis. These are usually IgA antibodies. There is a clear distinction between the two terms, the vesicle and bulla. The vesicle are the morphologic lesions that are characterized by fluid-filled raised lesion less than 5 mm across, and the bulla are the fluid-filled lesions, raised lesions that are more than 5 mm across. Now, just to revise the classification of the bullous or blistering dermatosis, we can say that these can be divided into inflammatory and non-inflammatory types. The inflammatory are pemphigus, bullous pemphigoid, and dermatitis herpetiformis, while the non-inflammatory one are epidermolysis bullosa and porphyria. The pemphigus is the disease of the epidermis, while bullous pemphigoid, dermatitis herpetiformis, and epidermolysis bullosa are diseases of the basement membrane zone, while the porphyria is due to intracellular accumulation. Then there are some unrelated conditions that also present with the bulla formation. These are herpes virus infection, spongiotic dermatitis, erythema multiforme, and thermal burns. But these are not considered in the blistering dermatosis. These bullous disorders of the skin can be fatal in some instances if untreated. And as we have seen the distribution of antigenic component, these bullous disorder may present with different type of the bulla, and these can be subcorneal blister, suprabasilar blister, or subepidermal blister depending on the pathological process involvement. In the subcorneal blister, the roof of this blister is formed by stadium corneum, while the rest of the epidermis forms the floor. While in suprabasilar blister, the basal layer is separated from all the above layers of the epidermis, while there is complete separation of the epidermis from the dermis in subepidermal blister. Pemphigus is a word that is derived from Greek word pemphigs, that means bubble. It is a blistering disorder caused by autoantibodies that result in the dissolution of the intercellular attachment within the epidermis and mucosal epithelium. It is almost equally common in male and female both, and common between the 4th to 6th decade of the life. There are many variants of this pemphigus, such as Pemphigus vulgaris, Pemphigus vegetans, Pemphigus foliaceus, Pemphigus erythematosus, or paraneoplastic pemphigus. Usually, these disease is benign but can be fatal if untreated. Vulgaris means common. So Pemphigus vulgaris is the commonest type of the pemphigus, and it is present in more than 80% of the cases. The at risk population are Jewish and Mediterranean populations. It involves the mucosa and skin both, especially the skin of the scalp, face, axilla, groin, trunk, and point of pressure, and it is accompanied by oral ulcers as it involves mucosa also. So these oral ulcers may persist for months before the skin involvement or skin lesion appears. The primary lesion of the skin shows superficial vesicle and bullae that rupture easily, and they leave behind a shallow erosion, or subsequently it may convert into plaque, and these shallow erosion are covered with dried serum and crust. The other types of the pemphigus are Pemphigus vegetans, foliaceus, erythematosus, paraneoplastic pemphigus, drug-related and disease-related pemphigus. So these Pemphigus vulgaris are characterized by flaccid bulla presence, and these are present on scalp, face, axilla, groin, trunk, and point of pressure. And these leave a shallow ulcer that are covered with dried serum and crust, involve both the mucosal surface as well as the epidermis. The pemphigus vegetans are rare, and they present not with blisters but with large, moist, verrucous or wart-like vegetating plaques that are studded with pustules, and they are present in groin, axilla and flexural surfaces, while the pemphigus foliaceus is benign form that is endemic in Brazil, and there it is termed as Fogo selvagum. It is present sporadically in other geographical locations also, and the sites affected are face, scalp, chest, and back. the mucosal involvement is very rare. These are very superficial. These pemphigus foliaceae are very superficial and they mainly present as areas of erythema and crusting. The superficial erosions are there at the site of blister rupture and they are characterized by presence of antibodies against desmoglein 1. The pemphigus erythematosus is a localized and less severe form of the pemphigus foliaceus, and it is named so because it affects the malar area of the face, the area where the lesion or erythema of the systemic lupus erythematosus is seen, the malar area, so it is termed as pemphigus erythematosus. The paraneoplastic pemphigus is associated with malignancies, especially non-Hodgkin lymphoma. Then there are some drugs that produce same sort of lesion. These are penicillamine and captopril, and disease-related pemphigus is seen in myasthenia gravis, lupus erythematosus, and benign thymomas. The pathogenesis of the pemphigus revolves around the desmogleins that are intracellular adhesions and that are the responsible for intracellular adhesions. There are development of immunoglobulin G against these desmoglin that result in loss of these adhesions and subsequently blisters are formed. When directly immunofluorescence is applied, that produces a net-like appearance of intracellular IgG deposits. So these fluorescein is staining all the keratinocytes that are present there and producing a net-like pattern. The desmoglin 3 IgG against desmoglin 3 are usually uh, present in this pemphigus vulgaris. This direct immunofluorescence is showing the net-like appearance of these keratinocytes. These are the IgG stained by this fluorescein and almost covering all the cells that are present in the epidermis. So this is the pemphigus vulgaris. The development of immunoglobulin G against the desmoglin is the main event that lead to the development of antigen antibody complexes that are deposited around the keratinocyte. When these antigen antibody complexes are formed, they are responsible for dissection, and this is augmented by activation of the plasmin through the plasminogen activator, and these events are further enhanced by internalization of the antigen antibody complex, disappearance of the attachment plaque, and retraction of the perinuclear tonofilament. All these lead to the development of intraepidermal blisters through the action of proteases. So now to describe the pathogenesis of the pemphigus, you can see that there is the presence of antibodies against the desmoglin, and these antigen antibody reaction, they result in the activation of the plasmin, and these proteases then are expressed into that environment around these keratinocytes that have got the desmosomes, and these desmosomes are lysed by these proteases and and there is disruption of the morphology. The tonofilaments, they retract. The intracellular cement substance, that is the desmoglin, is reduced. Desmosomes are also disturbed. So this lead to tonofilament accumulation around the nucleus, and the desmoglin, the desmosomes are now present as remnants. This will lead to the formation of suprabasal blister. So in all forms of the pemphigus, the morphological or histological findings are acantholysis, that is the separation of the individual keratinocyte, and as we have seen in the pathogenesis section, they become morphologically different. They become from polyhedral to rounded in shape, as there is accumulation of the keratin or tonofilament around the nuclei. Then there is superficial dermal infiltrate that is present uh, in almost all of these pemphigus varieties, and this is composed of lymphocyte, macrophage, and eosinophil. The pemphigus vulgaris and vegetans, characteristically they present with the uh, suprabasal blisters, and there is only a single layer, basal layer, that is lying intact with the dermis, and all layers that are above this basal layer have been separated by this immunologic process, and due to this is due to desmoglein 3 antibodies, the antibodies against the desmoglein 3, and due to this separation of the basal layer, it gives a characteristic appearance of the tombstone that are arranged in a row. So this is the tombstone appearance of the basal keratinocytes. In vegetans type of the pemphigus, that is morphologically characterized by wart-like appearance, there is epidermal hyperplasia is seen. While in pemphigus foliaceus, this is due to desmoglein 1 antibodies, and there is intraepidermal blister formation that is at the level of stratum granulosum. So here you can see that stratum corneum has been separated from the lower layers of the epidermis. So subcorneal blister is formed in pemphigus foliaceus, while suprabasilar blister in pemphigus vulgaris and vegetans. So this photo micrograph is showing a suprabasal blister that is showing characteristic tombstone appearance of these basal keratinocytes, that is marked by this arrow, black arrow, and this is due to antibodies, IgG antibodies against the desmoglein 3. So the treatment for the pemphigus is the corticosteroid initially, and then for the maintenance of the treatment, immunosuppressive agent can be used. Prognosis is very bad. It is the 10-year mortality for the pemphigus is less than 10% with treatment. And there are two other diseases that resemble the same histology. One is Hailey-Hailey disease, that is familial benign chronic pemphigus, and it is due to mutation in the ATP2C1 gene, and these are the proteins that act as calcium and magnesium pump. So due to disruption of these calcium and magnesium pump, there is lysis of these or detachment of these keratinocyte. Another disease is Groover disease, that is transient acantholytic dermatosis, that is related to the fragility of the skin due to uh, old age and sun damage. The bullous pemphigoid is a common autoimmune blistering disease which has got clinical similarities to the pemphigus vulgaris, but it lacks acantholysis. This disease is almost equally common in both male and female, and it affects elderly individuals. The presentation of this disease is variable, and the site affected usually are inner aspect of the thigh, flexor surface of the forearm, axilla, groin, and lower abdomen. The oral lesions appear after cutaneous lesion and they are present in 10 to 15% of the cases and may present as a urticarial plaque and severe pruritus. The course of this bullous pemphigoid is self-limited but chronic, and the patient general health condition is usually unaffected. The treatment is by systemic glucocorticoids. The lesion of the bullous pemphigoid are blisters that are tense and filled with clear fluid. And the base of the skin is appearing erythematous or normal. The size is usually less than 2 centimeter in diameter, but it occasionally can go up to 4 to 8 centimeter. These bulli do not rupture easily. Then, if this is not infected, a scar is not formed usually. Uh, These bulli are subepidermal and non-acantholytic blisters, and the infiltrate is usually superficial and sometimes it is deep perivascular infiltrate, and it is composed of lymphocyte and variable number of eosinophil, especially these eosinophils are present in early lesions. There is superficial dermal edema and also vacuolization of the basal cell layer. The eosinophils are typically present directly beneath the epidermal basal cell layer. So bullous pemphigoid are associated or characterized by presence of tense bulla, and here you can see in this picture there are two bulli. One is larger and another one is smaller, pointed by these arrows, and these are common on the flexural regions, axilla, groin, forearm, and abdomen or inner. So here you can see there are multiple bulli present, and these are tense bulli, and some all of these have got erythematous base, but some bulli have been ruptured and formed erosions. The histologically, this photomicrograph is showing that whole of this epidermis is forming the roof of this bulla, and the floor is formed by the edematous papillary dermis. This photomicrograph is showing the histological characteristic of the bullous pemphigoid. There is subepidermal blister, and this is not showing any acantholysis, so this is a non-acantholytic blister. There is presence of inflammatory infiltrate and edema in the superficial dermis, and also there can be presence of this fibrin. This is the pink material marked by this arrow. The fibrin can also be present. The inflammatory infiltrate that is present in bullous pemphigoid can be lymphocyte, eosinophil, and neutrophils. And these lesions heal without scarring if not infected. Now we can recall that the antigen for bullous pemphigoid are located within the hemidesmosomes. These are there is a bullous pemphigoid antigen 1 that is 230 kD or kilodalton molecular weight, and it is connecting this intracellular structural protein with the bullous pemphigoid antigen 2 that is 180 kD protein, and it is attaching these tonofilaments or intracellular structures or structural protein or intracellular skeleton with the lamina densa that has many molecules of type 4 collagen. The bullous pemphigoid is another autoimmune blistering disease, and in this autoimmune blistering disease, the immunoglobulin G are directed against the bullous pemphigoid antigen 2, and as a result, the antigen antibody complexes are formed, and it results in activation of the complement. The membrane attack complex is C5b to C9, and it results in plasma membrane basal cell plasma membrane injury, and that will interfere with the elaboration of adherence factor that are secreted normally by the basal keratinocytes. The anaphylotoxin, that is C3A and C5A, will result in mast cell degranulation that will result in release of chemotactic factor, and these chemotactic factor will recruit eosinophils, neutrophils and lymphocytes. The level of interleukin 5 and eotoxins are increased in blister fluid. Then eosinophil and neutrophil have got these eosinophil have got eosinophilic peroxidases and major basic protein. There is a release of proteases from the mast cell also, and neutrophil also release proteases. All these will have got tissue damaging effect, and due to this there is dermal epidermal separation within the lamina lucida. So this illustration is showing that there is the presence of bullous pemphigoid antigen antibody complex, and this antigen antibody complex fixes the complement that result in anaphylotoxin activation, and there is mast cell degranulation. And due to mast cell degranulation, there is a release of ECF, interleukin 5 and eotoxin that recruit eosinophil to this environment, and due to eosinophilic recruitment, there is eosinophilic degranulation, that as a result of substances that are present within the eosinophil, they separate this basal layer of the epidermis, the basal keratinocyte, at the level of lamina lucida, and result in subepidermal abscess. On immunofluorescence, these bullous pemphigoid are marked by presence of the linear deposits at the dermoepidermal junction, and ultrastructurally or in electron microscopy, the location of this bullous pemphigoid antigen is within the hemidesmosome that attaches the basal keratinocyte to the lamina lucida of the basement membrane zone. So when these hemidesmosomes are detached, it will result in the blister formation at the level of lamina lucida. This is another photomicrograph showing the immunofluorescence, and this immunofluorescence in bullous pemphigoid is exhibiting the presence of linear deposit along the dermoepidermal junction. So as the name suggests, this dermatitis herpetiformis is manifested by a tricharia and grouped vesicles. This herpetiformis is due to presence of the vesicles like that of herpes. This is a disease that is more predominant in male, and affecting third and fourth decades, and it is associated with celiac disease, and the lesions are plaque and vesicles that are extremely pruritic. This is an intensely pruritic eruption with a tricharia-like plaque and a small epidermal vesicle over the extensive surface of the body. The dermatitis herpetiformis is a disease that occurs in genetically predisposed individuals who are having HLA-D8, HLA-DR3 and HLA-DQW2 haplotypes, and there is uh, antibodies development against dietary gluten, and these dietary glutens that are derived from wheat protein gliadin, wheat, barley, rye and oat, they have got developed antibodies against these, and these IgA antibodies, they cross-react with the reticulin, that is the anchoring fibrin, and this anchoring fibril joins the epidermal basement membrane with the superficial dermis. So when this anchoring fibril is disturbed, there is development of subepidermal blister, and this condition is associated with increased level of IgA antibodies to transglutaminase and also increased levels of antibodies to the smooth muscle endomysium. This condition does not fix complement, rather there is recruitment of few neutrophils that secrete leukotrienes, and as a result of this there is recruitment of more neutrophils, and as a result of secretion of lysosomal enzymes there is degradation of laminin and collagen 4. So dermatitis herpetiformis develops when there is partially digested gluten in the lumen of the small intestine of B8, DR3 and DQW2 haplotype patient. This partly digested gluten, it travels through the defective mucosal epithelial barrier and binds to the IgA in the submucosa. Hence, immune complexes are formed that are taken to the circulation, and these immune complexes these immune complexes bind with the ligand, and these ligand are present just below the lamina densa of the basement membrane zone, and here this interaction lead to the release of neutrophil chemotactic factor, and this neutrophils then migrate to the tip of the dermal papillae. Recruitment of the neutrophil then releases various lysosomal enzymes within this dermal papillae, and due to these enzymes there is dissolution of the basal rootlets and anchoring fibrils, and the start of the dermoepidermal separation occurs. Then these neutrophils are present at the dermoepidermal junction, but they release various lysosomal enzymes and proteases. These proteases then spread along the dermoepidermal junction, and the spread of these enzymes will result in separation of the dermis, and the epidermis, and lifting away of the lamina densa. The lesions of the dermatitis herpetiformis are bilateral, symmetric, and grouped, and these are erythematous blisters. The site of these lesions is extensor surfaces, elbow, knees, upper back, and buttocks. They present with crusted lesions and no intact vesicles usually, because they are intensely pruritic. Then now, dermatitis herpetiformis, how the morphology of this lesion evolves. First, there is perivenular infiltrate of the lymphocyte, and soon after there is neutrophilic infiltrate that is deep to the lamina densa in the dermal papillae. These neutrophils increase in number, and within 12 hours they have got a cluster of 10 to 25 of neutrophil, and these neutrophil are present at the tip of the dermal papillae, and here they can produce two type of the morphologies by the action of their lysosomal enzyme or proteases. One is the sheet-like spread of the neutrophil, and these neutrophils are of 1 to 2 layers in thickness, and they result in whole separation of the dermoepidermal layers. This is complete separation, so the roof of this bully are composed of epidermis, while the base is of lamina densa and papillary dermis, while another morphology is the involvement of dermal papillae tip only. In that case, there is tear of the epidermis across the adjacent rete Here the release of these enzymes that are secreted by these neutrophil, what happens that there is disruption of the basement membrane zone in the lamina lucida and superficial part of the papillae, and there is tear of the epidermis across the adjacent ridges, and this tear will result in the formation of the bulla, that the roof of which is composed of alternating tear across the epidermal covering, and base is composed of residual epidermal pegs alternating with the basal half of the dermal papillae. These events lead to formation of microabscesses, and these microabscesses are formed by the accumulation of fibrin and neutrophil that are selectively accumulated at the tip of the dermal papillae. Then basal layer shows vacuolization, and there is focal dermoepidermal separation. And when these areas of dermoepidermal separation coalesce, they form subepidermal blister. Direct immunofluorescence of these areas show discontinuous granular deposits of IgA that are localized at the tip of the dermal papillae. The treatment of dermatitis herpetiformis is gluten-free diet, dapsone, and sulfapyridine. So this dermatitis herpetiformis is characterized by areas of urticaria with grouped vesicle formation on the extensor surfaces, elbow, knee, upper back, and buttock. There is presence of papillary microabscess and subepidermal blister. So this photomicrograph is showing dermatitis herpetiformis, that is showing the presence of these microabscesses at the dermal papillae, and underlying this there is vesicle at the dermal epidermal junction. In dermatitis herpetiformis, these IgG or IgA antibodies are directed against the reticulin, that is an important part of the anchoring fibril, and it connects the epidermis or epidermal basement membrane to the dermis. In the non-inflammatory blistering disorders, we have got two entities. One is Epidermolysis bullosa and another is Porphyria. Epidermolysis bullosa is a disease of the dermoepidermal junction or the disease of the basement membrane zone. This is a group of disorders that are caused by inherited defects in the structural protein that give mechanical stability to the skin. The presentation is at the time of the birth or soon after the birth, and with blisters at the site of pressure, rubbing, or trauma. Clinical spectrum may be of minor problem to a widespread life-threatening blistering disease. There are four types of this disease: simplex type, junctional type, scarring and dystrophic type, and mixed type. So the epidermolysis bullosa, the simplex type of this disease, is most common and present in 75 to 80% of the cases. It is inherited as autosomal dominant disorder, and it is mutation in the gene encoding keratin 14 and keratin 5 that pair to form keratin fiber. Then junctional variety. In this type, the blister occur in otherwise histologically normal skin precisely at the level of lamina lucida, and it is due to defected subunit of the laminin. This laminin is a multi-component unit or protein that is located in the lamina lucida, and it binds to both the hemidesmosome and anchoring fibrils. Some cases of this junctional type are also associated with mutations in Bullous pemphigoid antigen 2. Then scarring dystrophic type. In this type, the blister develop beneath the lamina densa in association with rudimentary or defective anchoring fibrils. And these are associated with mutation in COL7A1 gene, and it is inherited as autosomal dominant or autosomal recessive. Then there is a mixed type in which the pathology is at various level. So the epidermolysis bullosa simplex type, also termed as epidermolytic epidermolysis bullosa, is the most common variety of this disease that is common in more than 3/4 of the patients, and it is inherited as autosomal dominant disorder. This is due to mutation in the genes encoding keratin 14 and keratin 5. The gene for keratin 14 is located at the long arm of chromosome 12, while the keratin 5 is located on the long arm of the chromosome 17. Both these keratin, they pair to form a keratin fiber, and when they are not able to form a keratin fiber, they are not going to give support to the cell and result in cytolysis of the basal keratinocyte that result in blister formation. In the basal cell, there is first appearance of subnuclear vacuoles. These vacuoles then enlarge and coalesce, and when these are joined together, they form a subnuclear vacuole that starts the cytolysis or breakage of the cell at this level. So the roof of this blister is formed by almost intact epidermis with a fragmented basal layer, while the base is formed by a bit of the basal cell cytoplasm that are attached to the lamina densa, that is on histological H&E sections is basal pink line. So here you can see this line, cleavage line or site of the cleavage is showing that there is the separation subnuclearly, and below the nucleus there is separation of these basal cells, and this is evident histologic like this. So blister is formed and the lower area has got bits of the basal cells, while intact epidermis along with fragmented basal cell layer is forming the roof of this blister. The junctional type of the epidermolysis bullosa appears as blister that occur in otherwise histologically normal skin, and this blister is present precisely at the level of lamina lucida. It is inherited as autosomal recessive disorder, and it may present as benign disease with no effect on lifespan or severe condition that is fatal within first 2 years of the life. This disease is got association with abnormalities of the nail and teeth also. The benign disease is due to mutation in the genes for type 7 collagen. The gene is present at the long arm of chromosome 1 and long arm of chromosome 10, while the severe condition that is fatal within first 2 years of the life is due to defected subunit of laminin or integrin, and these are located within the lamina lucida. The laminin bind to both the hemidesmosomes and the anchoring fibrils, and the mutations are of at the long arm of chromosome 1 and long arm of chromosome 18. Some cases of this junctional variety are also due to mutation in Bullous pemphigoid antigen 2. The blister is formed by an intact epidermis that forms the roof of the blister, while the base is formed by intact lamina densa, and this blister is within the lamina lucida. So this illustration is showing that this blister is present and whole of the epidermis is intact and forming the roof of the blister, while the lamina densa is present at the base. So here this illustration is showing that this cleavage line is present within the lamina lucida. Subdesmosomal plate is also above, and lamina densa is in the lower area and forming the base of this blister. In the scarring dystrophic type of epidermolysis bullosa, that is also termed as dermolytic epidermolysis bullosa, this is transmitted as both as the autosomal dominant and autosomal recessive type. The autosomal dominant is benign form, while autosomal recessive is severe form of this disease. There is development of blister that are present beneath the lamina densa in association with rudimentary or defective anchoring fibrils, and these are also associated with the abnormalities of the nail and teeth, and there is actually mutation in COL7A1 gene that is present on the short arm of chromosome number 3. The anchoring fibrils that make up the net in the upper dermis, and through this net the collagen type 1 and type 3 fiber course, and this structure anchors epidermis to the dermis. So in the dermolytic epidermolysis bullosa or scarring dystrophic type of epidermolysis bullosa, the roof of the blister is formed by intact epidermis, lamina lucida and lamina densa, while the base is formed by outer part of papillary dermis. Here you can see the complete epidermis along with the basement membrane zone, lamina lucida and lamina densa, are lifted up by a blister that is present above the outer part of the papillary dermis. This illustration is showing the site of cleavage. In this site of the cleavage in this illustration is below the lamina densa and at the level of these anchoring fibrils, and these anchoring fibrils are dividing the epidermis from the dermal structures and resulting in a blister formation. The Kindler syndrome is another type of epidermolysis bullosa, and it is transmitted as autosomal recessive disorder. There is a gene that is FERMT1 gene, and it is located on short arm of chromosome 20, and it encodes kindlin-1 gene, and this gene, this kindlin-1 protein is an adhesion molecule between basal keratinocytes. When this gene is mutated, as it is an autosomal recessive disorder, it will result in blister formation at mixed cleavage plane. This disease should be differentiated from other types of epidermolysis bullosa, because by this Kindler syndrome has got poikiloderma, that is mottled pigmentation of the skin, and it is related with photosensitivity. The epidermolysis bullosa in this picture, the junctional variety of the epidermolysis bullosa, it shows typical erosions that are present in the flexure creases, while the microscopy is showing that this is present at the level, this blister is present at the level of the lamina lucida, and there is no associated inflammation present. The porphyria are a group of uncommon inborn or acquired disturbance of porphyrin metabolism. The porphyrin are important component of hemoglobin, myoglobin, and cytochrome. The types of porphyria are congenital erythropoietic porphyria, erythrohepatic protoporphyria, acute intermittent porphyria, Porphyria cutanea tarda, and mixed porphyria. The cutaneous manifestation of this disease are urticaria and vesicle formation that are related to sun exposure, and these vesicle or blisters are subepidermal, and dermis contain vessels that are thick walled, and there is glassy deposits of serum proteins. The pathogenesis is not known. So these porphyria are due to genetic deficiency of one of the enzyme that is required for the synthesis of heme. So there is increased production of porphyrins. The diagnosis is by excretion of intermediate products in the urine, delta amino levulinic acid, porphobilinogen, uroporphyrin, coproporphyrin, or protoporphyrin. Then types are erythropoietic or hepatic. So in erythropoietic porphyria, there is defective synthesis of heme in the red cell precursors in the bone marrow, and there are two types of this. One is the congenital erythropoietic porphyria, in which urine is red due to presence of uroporphyrin and coproporphyrin, and erythropoietic protoporphyria is due to excess of protoporphyrin but no excess of porphyrin in the urine. The hepatic type of porphyrias are more common, and there is erythroid precursor that is normal, but the hepatic synthesis is defective. There is acute intermittent porphyria that is characterized by acute episode of three patterns: abdominal, neurological, and psychotic. And the first photosensitivity is acute intermittent porphyria is absent. The urine has got increased delta aminolevulinic acid and porphobilinogen, while Porphyria cutanea tarda is most common of all porphyrias, and these porphyrins collect in the liver and a small quantity is excreted in the urine. The skin lesions are similar to those in variegate porphyria. It complicates by cirrhosis or hepatocellular carcinoma. The mixed variety is or variegate porphyria is rare, and it has got combined the skin photosensitivity with acute abdominal neurological manifestation. This picture is exhibiting the features of the Porphyria cutanea tarda, the cutaneous lesion of Porphyria cutanea tarda. Here in porphyria, the blister is present, and this blister is also non-inflammatory, and it is present at dermoepidermal junction, and the dermal papillae are rigid at the base, and they contain abnormal superficial vessels, thick-walled blood vessels. So this table is summarizing all the diseases that are associated uh, with the blister formation in the skin and their differentiation. So this is the case scenario that I introduced in the start of this video. So what could be the possible diagnosis? Thank you very much for your attention.